I'm a GI medical oncologist at Vanderbilt Ingram Cancer Center. I help lead our neuroendocrine tumor program, and it is my real pleasure to be giving this talk titled Emerging Targets for Well-Differentiated Neuroendocrine Tumors, Choices and Selection. I'd like to thank the organizing committee for this opportunity today. Here are my disclosures. My primary disclosure is that there will be discussion of off-label therapeutics during this talk. With regards to a roadmap for the talk, I'd like to start with talking about the current targets in neuroendocrine tumors, how to choose among available treatment options in the clinics, novel targets in neuroendocrine tumors, combination therapies, and ongoing questions for the field, with the latter categories focused on radionuclide therapy, given the theranostic focus of this workshop. So what are the targets in neuroendocrine tumors? There are a number of proteins both on the surface and cascading pathways that are currently targeted in the clinic. Some of the main players here include somatostatin receptor 2, which is targeted by agonists such as the somatostatin analogs, as well as peptide receptor radionuclide therapy. Other key targets include the mTOR pathway, which is downstream of PI3 and AKT and plays critical roles in neuroendocrine tumor growth and oncogenesis. And we have upstream receptor pathways such as vascular endothelial growth factor, which are targeted by agents such as sunitinib and several of the other tyrosine kinase inhibitors that we will touch on in this talk. With regards to the agent types we'll be discussing, we will primarily be focusing our efforts on radionuclide therapy. However, we will touch on anti-vascular endothelial growth factor as well as non-VEGF receptor pathway inhibitors in brief as well. So, focusing on the radionuclides that are currently being tested, both on trial and in the clinic, we start first with our basic schematic of PRRT, which we all know and are familiar with. The concept being a peptide is linked to a radionuclide. The radionuclide that is currently approved and has garnered regulatory licensure in many countries across the world is 177 lutetium. However, other beta emitters such as Y90 have been tested and originally were actually trialed first in some instances. Beyond beta emitters, there's a lot of excitement in the field about alpha emitters, compounds such as actinium-225, which has a long history of trials and use in India, as well as 212-lead and 213-bismuth are some of the other agents that are being tested currently. With regards to PRRT types that use different peptides, though most PRRTs currently utilize somatostatin receptor agonists, somatostatin receptor antagonists have also been tested. Saturreatide tetraxetan is an agent formerly known as JR11, which has some small phase 2 data, though there have been some concerns about myelosuppression with that agent. So what about the factors that influence our treatment selection? I think the primary factors that we utilize in the clinic include primary tumor origin and somatostatin receptor 2 expression. As we all know, somatostatin receptor 2 expression is now cataloged through the utilization of dotatate imaging, whether that's dotatate PET or dotatate MRIs. The uptake of that has really been transformative. So here we have a patient with a pancreatic neuroendocrine tumor with relatively low volume disease that's dotatate avid. In these instances in which a patient needs treatment, we usually start with a somatostatin analog, whether that's octreotide or lanreotide, based on patient body habitus and tolerance. Upon progression, we can think about things such as capecitabine plus temozolomide or PRRT with lutetium. And in no particular order in the later line setting, we think about agents such as everolimus and sunitinib, which have garnered regulatory approval for pancreatic NET patients, or some of the more novel tyrosine kinase inhibitors such as cabozantinib, surufatinib, and lenvatinib. Notably, all but surufatinib are off-label use, surufatinib the exception being in China, where it is approved for the treatment of patients with both refractory pancreatic and extrapancreatic neuroendocrine tumors. However, this approval is still being weighed in the United States. With regards to a patient with a midgut primary, again, we have a patient with a midgut NET with low-volume somatostatin receptor avid disease. We again think about the somatostatin analogs being our first line of therapy. And upon progression, it's usually a choice of PRRT with lutetium or everolimus. And typically upon progression, we think about VEGF TKIs in the clinical trial setting, whether that's cabozantinib, lenvatinib, and hopefully soon surufatinib to garner approval. Disease bulk also plays a very important role. So here we have a patient with a pancreatic neuroendocrine tumor with an extensive volume of disease encompassing much of the liver. In this case, I typically think about a debulking strategy. Until now, capecitabine plus temozolomide carries the most cytoreductive potential among all available therapies, and thus utilizing this as an initial therapy. In post-cytoreduction, I think there's a lot of different angles in which one can go, perhaps utilizing a somatostatin analog, and thereafter, only upon progression, thinking about things like PRRT. There is data for FOLFOX-based chemotherapy in patients with pancreatic neuroendocrine tumors, which tend to be the most chemosensitive of all of our neuroendocrine tumors. And if cytoreduction in a more biologically indolent behavior is achieved, one could then think about the tyrosine kinase inhibitors that are utilized in non-bulky NETs as well. Other factors that influence treatment selection include tumor size. This is some very interesting post-hoc data from the NETTER-1 trial. So in the post-hoc analysis from NETTER-1, several features were looked at as to whether they influence PRRT responsiveness or not. And one of the factors was the presence of a large tumor, defined in the study as a tumor that was greater than 3 centimeters in size. And what was quite striking is that patients in the lutetium-treated arm, pointed in blue in the Kaplan-Meier curve, had a strikingly different PFS based on the presence of even a single large lesion. So patients without a single large lesion had a 2-year progression-free survival rate of 90%, whereas patients with even one tumor of 3 centimeters or greater had a 2-year progression-free survival of 55%. And so tumor bulk and individually bulky lesions has to be a thought process when we think about PRRT currently with lutetium, and other strategies in which we can perhaps remove bulky tumors or better optimize their management to increase the effectiveness of PRRT. Other factors include tumor grade. So on the left-hand side, we have Kaplan-Meier curves from a retrospective analysis in pancreatic NETs, and we see that all of these patients were treated with lutetium dotatate, and we see that patients with the Ki-67 greater than 5% in the green line had reduced PFS that was strikingly different from patients with a Ki-67 of equal to or less than 5%. And I know Dr. Mitra will be talking extensively about the role of PRRT in well-differentiated grade 3 neuroendocrine neoplasms, but I just wanted to also raise the point that grade 3 neuroendocrine neoplasms treated with PRRT have a much shorter progression-free survival compared to grade 1 and grade 2 tumors. So perhaps in the context of dealing with patients with well-differentiated grade 3 neuroendocrine neoplasms, PRRT may be utilized as a treatment, but perhaps not in an earlier setting, or perhaps not first. So how to choose among existing therapy? Several tools, both clinical and biomarker-based, have been developed. One of the tools that I've been fortunate to be a part of the development for is the clinical score. So this is a score that's comprised of 5 categories which have been vetted and scored through a multidisciplinary tumor board evaluation. This is a score that was prospectively developed and has now been validated in external cohorts. This manuscript should be coming soon, and we are hopeful to actually incorporate the score as well into prospective studies to actually see if, beyond prognostic implications, it carries predictive implications. But the 5 constituents of this score include patient symptoms, tumor bulk and critical organs, non-PRRT treatments available based upon primary tumor origin, presence of peritoneal carcinomatosis, and previous systemic therapies received. So this is some of the validation data from the SCORE. On the left is a Kaplan-Meier curve of progression-free survival. On the right is a Kaplan-Meier curve for overall survival. So the green line refers to patients with who received 3 to 4 doses of PRRT. The solid green line refers to patients with a clinical score of 4 or less, which was the cut point in our data, and we see a 3-year progression-free survival of close to 75%. The dashed green line refers to patients who received 3 to 4 doses of PRRT, but who had a clinical score greater than 4, and we see a 3-year progression-free survival of much, much lower, less than 10%. Quite interestingly in our data, patients who only got 1 to 2 doses of PRRT in the red, solid, and dashed lines respectively had the lowest progression-free survival benefit from PRRT. And we can see that with regards to overall survival, a similar trend was observed based upon PRRT's utilization. So based upon this data, there is a suggestion that the utilization of PRRT when patients are less pretreated and have lower disease burdens may influence the effectiveness of the therapy. Other factors such as the biomarker tool called the PRRT predictive quotient, or the PPQ, is a biomarker which has actually been validated in multiple external cohorts. This is a combined biomarker comprised of mRNA gene transcripts as well as IHC-based Ki67 grading. And based on the readouts, patients' tumors are assigned basically the score of a positive PRRT responder or a negative PRRT non-responder. This is the validation data for the PPQ. Looking at the 3 cohorts, so in the cohort from Mediola, we see patients with a positive PPQ had a PFS with lutetium PRRT that was not reached, and a median PFS in the PPQ negative group of only 11 months. In the Bad Burka cohort, we see a very similar median PFS not being reached in the PPQ positive patients, whereas in the PPQ negative patients, median PFS was 14 months. And in the Rotterdam data, we see a median PFS of not reached in the PPQ positive patients, and median PFS of about 10 months in the PPQ negative patients. Quite interestingly, patients who were treated in the controls cohorts of each of these validation sets, being treated with either octreotide or on observation, there was no correlation between PPQ positivity and response, suggesting that this may be a predictive biomarker for patients receiving PRRT. However, in clinic, the realistic implication is that even PPQ negative patients seem to derive some benefit from PRRT. And so the question becomes, even if a patient is PPQ negative with adequate somatostatin receptor expression, would one withhold PRRT? And at this point, that is, given the still lack of relative availability of options for patients with NETs, that would not influence our choice. However, this is something that in the future, as our treatments expand, may become more meaningful. So how else can we choose amongst existing therapies? So there are a number of very interesting sequencing studies that are ongoing that in the next several years will give us hints of how we perhaps should be optimally employing these therapies. The first of these studies is the NETTER-2 trial, which is a randomized phase 3 global study. In this study, patients with more biologically aggressive GEP-NETs with Ki67 indices of 10 to 55% will be randomized to 4 treatments of lutetium dotatate with accompanying octreotide or a higher dose of octreotide monthly. The primary endpoint of this study is progression-free survival, with key secondary endpoints of overall survival and response rate. The important questions in my eyes being addressed by this trial is that is PRRT a possible first-line treatment for patients with more aggressive G2, G3 GEP-NETs? And perhaps more importantly, because patients in the control arm are going to conceivably getting PRRT upon progression, is that the OS endpoint. And so is giving PRRT initially more effective than giving PRRT upon progression? Another sequencing study that's ongoing in France is the Oclo-Random study. This is a randomized phase 2 study in second-line patients with well-differentiated pancreatic NETs. Patients are randomized here to 4 cycles of lutetium dotatate or 37.5 milligrams of sunitinib daily, which is the approved dose. The primary endpoint of the study is 12-month progression-free survival, with the key secondary endpoints of best overall response and overall survival. The important questions that this trial is addressing is that should PRRT be sequenced ahead of sunitinib in the second-line setting in patients with pancreatic NETs, and what is the effectiveness of PRRT alone administered in the absence of concomitant somatostatin analog, which still remains a bit of a controversial topic given that no prospective data for PRRT alone in large settings exists. Another study that's ongoing in an unmet need population of bronchial NETs is NCT 5739. This is a randomized phase 2 study in the United States which just recently began accrual. In this study, patients with somatostatin receptor positive well-differentiated bronchial NETs are randomized to 4 cycles of lutetium dotatate or 10 milligrams of everolimus daily. The primary endpoint of the study is progression-free survival, with key secondary endpoints of overall survival, AEs, and response rate. The important questions being addressed by this trial is what is the effectiveness of PRRT in patients with bronchial NETs? Our hope is that if this study is positive, that this will lead to regulatory licensure for bronchial NETs in the United States and hopefully across the rest of the world thereafter as well. And the second question is that should PRRT be sequenced ahead of everolimus in patients with bronchial NETs? Because again, upon progression, it is assumed that patients in the everolimus arm will also be receiving lutetium dotatate. With regards to some of the novel targets in neuroendocrine tumors, one of the major areas of looking at combination therapies with PRRT are DNA damage repair pathways. As we know, PRRT with lutetium dotatate elicits single-strand DNA breaks, and in theory, adding agents which can perpetuate single-strand breaks into double-strand breaks should increase the effectiveness of PRRT, thus the motivation beyond for these studies. These are all early phase studies being conducted through the Experimental Trials Network of the National Cancer Institute. The first is the ribonucleotide reductase inhibitor triapine plus lutetium dotatate. This is a study that is accruing very well in patients with GEP-NETs. The second is a study of the PARP inhibitor olaparib plus lutetium dotatate in patients with GEP-NETs. This has not yet opened to accrual, but should be doing so quite soon. And the third study is the DNA PK inhibitor peposertib in combination with lutetium dotatate. And here, DNA PK has well-established data in combination with ionizing radiation to create more double-strand breaks as the motivation for this concept. And so this is a single-arm phase 1 study in patients with GEP-NETs, which has actually started to accrue. So the important questions that are being addressed by these trials are, one, can DNA damage repair inhibitors safely be added to PRRT? And second, can they elicit greater cytoreduction than lutetium dotatate alone, whose response rate is quite modest relative to some of our other therapies? Another novel target is alpha-emitting radionuclides. So this is an ongoing phase 2 study being led by Dr. Delpassand in Houston, utilizing lead dotamtate in SSTR-positive neuroendocrine tumor patients. The patients here are treated with 3 doses of lead dotamtate with a primary endpoint of maximum tolerated dose and defining the dose-limiting toxicity profile and the key secondary endpoints as listed. The important questions being addressed by this study is that is lead dotamtate safe to administer, and specifically what is the activity of alpha-emitting radionuclides in PRRT-naive patients? Another alpha emitter that's actually been tested and has well-validated data from prospective cohort through the AIMS group in India is actinium-225. This was a cohort study that was presented by Drs. Ball and Balal and has been published subsequently. In this study, patients with treatment post-lutetium dotatate, either with stable disease or refractory disease, were then treated with actinium-225. And what we can see is that in patients who are refractory to lutetium dotatate on the left, the response rate with actinium-225 was more than 40%. And in patients with a best response of stable disease to lutetium dotatate, actinium-225 produced a response rate of more than 60%. The patient images on the right are striking dotatate images from a patient with a rectal neuroendocrine tumor with extensive bony and liver involvement from the disease. And thereafter, after 2 cycles of actinium dotatate, we see essentially a complete response. So the important questions that were addressed by this prospective cohort analysis is that should alpha-emitting radionuclides be reserved for patients with either refractory disease or suboptimal responses to lutetium dotatate. And there are phase 3 studies that are in development looking at actinium as well as other alpha emitters post-lutetium dotatate that are currently in development. So what about non-radionuclides targeting somatostatin receptor 2? So one of the compounds that was recently tested is PEN-221, which is an antibody-drug conjugate conjugating DM1 or maytansine, a microtubule inhibitor, to a somatostatin receptor targeting ligand. This was data that was phase 2 data in midgut net patients that was presented by Dan Halperin at NANETS as well as ASCO this year. And what we can see is that in patients who had a prior 2 lines of therapy, this compound produced a median progression-free survival of 9 months. There were 2 cohorts, PRT naive and PRT recurrent patients or progressive patients, and the numbers were too small to make definitive conclusions in this setting. But based on this activity and the overall tolerability of the agent, a subsequent randomized study is being planned in patients with midgut net. Another somatostatin receptor targeting raw non-radionuclide therapy is tidutamab, which is a BiTE antibody which targets CD3 on the cytotoxic T cells and somatostatin receptor 2, with the premise that this agent may be able to bring in effector T cells into the tumor microenvironment for NETs. As we know, immunotherapy with checkpoint inhibitors has not yet been effective in this space, and so the thought is to see if this agent could be utilized. As with many BiTE antibodies targeting immune effector cells, cytokine release syndrome is a concern. However, in this study, 41% of patients experienced cytokine release syndrome, but in most cases it was grade 1 or grade 2. With regards to response, these patients were heavily pretreated, receiving a median of 4 prior lines of therapy. We saw the investigators rather saw no responses. However, stable disease was observed, and durable responses were also observed in this setting. So, while this phase 1 study is still ongoing, it appears that safety has been established, but this agent as a monotherapy drug may not hold as much promise as perhaps as in combination with checkpoint inhibitors, which studies for this are in current development as well. So with regards to combination therapies to perhaps overcome disease heterogeneity, we know that lutetium is 177 is a medium energy beta emitter. But what about combinations with a heavier energy beta emitter such as Y90? Several prospective approaches have explored this. The first was a phase 2 parallel enrolling cohort analysis looking at patients with primarily midgut and foregut NETs who were treated with either lutetium and Y90 in tandem or Y90 alone. And though this was not powered to be a comparative study, we see that the overall survival was significantly longer in patients treated with the tandem approach. A subsequent study, primarily in GEP-NET patients, also explored the utility of tandem therapy with Y90 and PRRT, and we see again significant improvements in progression-free survival and overall survival than anticipated at that time with either therapy alone. So based upon some of this phase 2 data, there is a ongoing non-randomized phase 2 parallel assignment study in patients with GEP-NETs, bronchial NETs, and other NETs called the PULNETs trial. In this trial, patients with somatostatin receptor positive NETs are treated with up to 4 cycles of Y90, and thereafter patients are either treated with 4 cycles of lutetium dotatate or 4 cycles of a 50-50 mixture of lutetium dotatate plus Y90. The main question that the study is seeking to ask is that does the addition of the more energetic beta emitter to lutetium dotatate increase the effectiveness as measured by progression-free survival, as well as response rate and overall survival experienced by patients? Radionuclide therapy plus chemotherapy is also being looked at. The control NET study was a parallel randomized phase 2 study in pancreas NETs and midgut NETs. Patients with pancreatic NETs were randomized in a 2-to-1 fashion to PRRT plus CAP10 or CAP10. Patients with midgut NETs were randomized in a 2-to-1 fashion to PRRT plus CAP10 versus PRRT. The median, or rather, the primary endpoints in the pancreatic NET cohort was 12-month PFS, and the midgut NET cohort was 15-month PFS. This is data that was presented from the Australian group at GI ASCO, and what we see is in pancreatic NETs, the combination of CAP10 plus PRRT elicited a greater 12-month PFS rate and a much deeper objective response rate with no additive toxicity that was observed. However, in patients with midgut NETs, there was no difference in 15-month progression-free survival. However, the grade 3-4 adverse events were much more significant in this setting. So perhaps in pancreatic NETs, there may be more of a role for combined therapy with CAP10 plus PRRT. And in thinking about the patients that may benefit from chemotherapy plus radionuclide therapy, what about patients with tumors with FDG avidity? It's well known that FDG avidity is a poor prognostic biomarker in patients with well-differentiated NETs, and furthermore in patients with well-differentiated NETs treated with PRRT. From the Kaplan-Meier curve on the right, predominantly in a pancreatic NET cohort, patients who were treated with lutetium dotatate experienced a marked reduction in progression-free survival compared to patients with FDG negative disease or non-avid disease. And this is well validated by the NET PET score, which many thought leaders around the world are now proposing that we use for perhaps even lower grade and well-differentiated patients to truly assess what extent of disease is FDG avid versus what degree is FDG negative. Based on the suggestion that FDG positive disease patients have more aggressive disease, a cohort study looking at capecitabine plus lutetium dotatate was initiated in patients with FDG positive GEP-NETs. In this study, most patients had pancreatic neuroendocrine tumors, and what was seen is that the objective response rate was 30%, disease control rate was close to 90%, and the median progression-free survival was 31.4 months, which is longer than the historical control data expected with PRRT alone. And we see that both pancreatic NETs and GI NET patients experienced meaningful progression-free survival benefit, also pointing to perhaps another cohort of patients, the FDG avid patients, in which radionuclide therapy plus chemotherapy may play a role. So where may immunotherapy plus radionuclide therapy play a role? Though single-agent checkpoint inhibitors have had disappointing activity in patients with well-differentiated NETs, there has been suggestions of activity in higher Ki67 neuroendocrine tumors, so the G3 population or atypical lung NETs. And there is preclinical work that treatment with lutetium dotatate can increase the infiltration of antigen-presenting cells and NK cells, which is observed on the diagram on the right. And based upon this work, an ongoing study, NCT 7948, is exploring whether pembrolizumab plus liver-directed therapy or in combination with lutetium dotatate carries activity. This is a non-randomized parallel assignment study. There are, however, other randomized studies in development exploring pembrolizumab plus PRRT in patients with G2 and G3 NETs. So at this point, it remains undefined which patients should be considered for combinatorial therapy. The patients in whom this approach may be most biologically plausible include patients with bulky disease, patients with higher grade tumors, patients with FDG-avid tumors, patients with pancreatic NETs. Several novel randomized trials with lutetium dotatate and lutetium dotatate combinations are currently in development, and some of the most exciting include DNA damage repair inhibitor, radiosensitizers, and immunotherapy combinations. So some of my parting thoughts include emerging questions for the field. The largest one that several trials are poised to answer is that where should lutetium dotatate be positioned relative to other available therapies? How should we define the optimal candidates for lutetium dotatate? Is it through a biomarker? Is it through things like the clinical score? Furthermore, some of the novel VEGF receptor tyrosine kinase inhibitors being developed, where do they fit in? And where do potential combinations of VEGF TKIs fit in the landscape? Where should alpha radionuclide therapy be positioned? Should it only be after beta-emitting therapy, or should it be used before? What about the hematologic long-term toxicities of potential combination approaches with lutetium dotatate? Will the risk of MDS be increased? And how long do we have to follow up to truly assess this risk? I think another interesting question is that will other somatostatin receptor targeting approaches, such as immunotherapy and some of the chemotherapy conjugates that I've discussed, will they carry the same activity as targeted radionuclide therapy has? Some of the early suggestions may point to the fact that they may be less effective, but this remains an active question. So with that, I'll close. I'd be happy to take any further questions. Thank you so much for your kind attention.